Okay, we're going to talk about alterations of cardiovascular function here. And our first is varicose veins. This is a vein where blood has pooled. They become distended, tortuous, and you can palpate them. They're caused by trauma or gradual venous distension. Risk factors: obesity, number one, the age, female gender, family history, pregnancy, DVT, and prior leg injury. Okay. The result: slow blood flow. Possible risk factor from that: blood clots. Possible risk factor from that: increased likelihood of stroke or heart attack. Chronic venous insufficiency, inadequate venous return over a long time due to varicose veins or valvular incompetence. You can get venous stasis ulcers as a result because of the lack of blood supply, right? The tissue can die. You can see thrombus formation, right? Obstruction of venous flow leading to increased venous pressure. The triad of Virchow is thought to be critical in the diagnosis and assessment of the risk factors of this. These are venous stasis, venous endothelial damage, hypercoagulable states. There are others, including cancer, orthopedic surgery and trauma, heart failure, and immobility. Superior vena cava syndrome, progressive blockage of the superior vena cava that leads to venous distension of the upper extremities and the head. This is an oncologic emergency. Okay. Hypertension is consistent elevation of systemic arterial blood pressure, a sustained systolic of 140 or higher, or diastolic of 90 or higher. And there are two types: there's primary and secondary. Okay. With primary hypertension, we contribute this to genetic and environmental factors. All right. It affects up to 95% of individuals with hypertension. Risk factors: high sodium intake, natriuretic peptide abnormalities, inflammation, obesity, insulin resistance, which really goes hand in hand with obesity. Okay. I mean, we should sort of link these together. All right. Let's do that. Right. Insulin, obesity, and insulin resistance. Uh, uh, you might even call these comorbidities. Okay. Because generally, when we're talking about insulin resistance, we're talking about type 2 diabetes. And most people with type 2 diabetes, at least on the journey to getting that, suffer from obesity. Okay. So, what do we do about that? Well, we treat the underlying cause. All right. This is going to be a change in diet and exercise regimen. And also, there are going to be some medications you're going to be prescribed. Okay. Secondary hypertension is caused by disease that raises peripheral vascular resistance or cardiac output. Generally, this is going to be a problem with kidney function. Okay. Renal vascular, parenchymal disease, adrenal cortical tumors, adrenal medullary tumors, and drugs. Okay. So, again, we're talking about problems related to the endocrine and urinary system. Okay. And once you fix the underlying cause, the hypertension usually goes away. Complicated hypertension, chronic hypertensive damage to blood vessels and tissues leading to target organ damage in the heart, kidney, brain, and eyes. Myocardial hypertrophy can be a result of this. Why? Because you increase the afterload. Okay. When you increase the force against which the heart has to work, the myocardium has to work harder and it will hypertrophy. Okay. Your heart will enlarge. Malignant hypertension is a progressive hypertension, a diastolic pressure above 140, and it can result in life-threatening organ damage. Okay. Orthostatic hypotension is a decrease in both systolic and diastolic blood pressure when you stand. Lack of normal blood pressure compensation in response to gravitational changes on the circulation. You can have either acute or chronic orthostatic hypotension. Okay. Often these can result in syncope. Okay. Which is a fancy word for fainting. Okay. An aneurysm is a local dilation or outpouching of the vessel wall or cardiac chamber. True aneurysms include fusiform, circumferential, and saccular. False include extravascular hematomas that communicate with the intravascular space. An aorta is often susceptible, especially the abdominal aorta. Causes include atherosclerosis and hypertension and can lead to aortic dissection or rupture. Okay, when we say aortic dissection, we mean that it develops openings. Okay. All right, so you can see what they look like here, right? A fusiform circumferential aneurysm, okay, a fusiform saccular aneurysm, a dissecting saccular aneurysm. Notice the opening, okay, okay, and then a false aneurysm, right, where the clot is invading the wall and weakening it, okay. Thrombus formation, a blood clot that remains attached to the vessel wall. Risk factors include intimal injury and inflammation, obstruction of flow, and blood pooling, or what we call stasis. Okay. Thromboemboli and arterial thrombi. A bolus is just an embolism is just a bolus of matter circulating in the bloodstream. It becomes a thrombus when it's stationary, when it's blocking flow. It can be an air bubble, it can be amniotic fluid, aggregates of fat, bacteria, cancer cells, foreign substance. Doesn't really matter what it is. It can even be a blood clot. Okay. As long as it's bigger than the opening it's trying to get through, it can graduate from an embolism to a thrombus, right? Thromboangiitis obliterans, or Berger's disease, is a rare disease that causes inflammation and swelling of small and medium blood vessels, especially in the hands and feet. The swelling can prevent blood flow, lead to pain, tissue damage, and blood clots. The disease can cause pain, tenderness, or burning in the lower legs or feet when walking, as well as pain or tenderness in the hands and the forearms. Okay. It's associated with smoking. It is thought to be an autoimmune disease. Um, we see thrombi filled with inflammatory and immune cells that become organized and fibrotic, resulting in permanent blockage and obliteration of portions of small and medium-sized arteries in the feet and hands, causing pain and tenderness. Symptoms are caused by slow blood flow, can often lead to gangrenous lesions and amputations, right? You cut off blood flow, you cut off oxygen and nutrient supply, the tissue can die. Okay. Raynaud's phenomenon, also called Raynaud's syndrome, is a condition that causes spasms in small arteries, which restricts flow to the extremities. This usually affects the fingers and toes, but can also affect the nose, ears, nipples, and lips. Okay. Um, Primary Raynaud's is a vasospastic disorder of unknown origin, while secondary Raynaud's is usually the result of underlying systemic diseases such as collagen vascular disease, smoking, pulmonary hypertension, myxedema, and cold environments. Manifestations, pallor, cyanosis, cold, and of course, pain. Okay. Arteriosclerosis is a chronic disease of the arterial system, resulting in an abnormal thickening and hardening of the vessel walls, while atherosclerosis is a thickening and hardening caused by the accumulation of lipid-laden macrophages in the arterial wall that generate plaque. The progression, inflammation of the endothelium, cellular proliferation, macrophage migration and adherence, foam cell formation, fatty streaks, fibrous plaques, then complicated plaques. Risk factors, diabetes, smoking, hyperlipidemia, dyslipidemia, hypertension. resulting in inadequate perfusion, ischemia, and necrosis. Okay, so let's look at the progression here.
Atherosclerosis is a life-threatening disease that may have begun to develop during childhood. This condition is a process in which deposits of fatty material, called plaque, build up inside the walls of arteries, reducing or completely blocking blood flow. In extreme cases, this disease can lead to a heart attack or a stroke. Risk factors for atherosclerosis include high blood pressure, high cholesterol, tobacco smoke, diabetes, obesity, and physical inactivity. Although the exact causes of atherosclerosis are not clear, many scientists think it begins with damage to the inner wall of an artery, called the endothelium. Over time, substances traveling in the blood, such as cholesterol, fats, and cellular waste products, accumulate inside the damaged area of the arterial wall. Chemical reactions occurring within the buildup of material cause cholesterol molecules to oxidize. This initiates an inflammatory response in which the endothelial cells at the damaged site release chemicals that signal a call for help. In response, monocytes from the bloodstream travel to the damaged site. Stimulation from oxidized cholesterol converts the monocytes into macrophages. The macrophages eat and digest the cholesterol molecules. As a result of this process, the macrophages change into foam cells, which accumulate to form plaque. As the plaque increases in size, the arterial wall thickens and hardens. At the same time, smooth muscle cells within the arterial wall begin to multiply. Then, most of the smooth muscle cells move to the surface of the plaque. These cells contribute to the formation of a firm, fibrous cap covering the plaque. Over time, the cap may erode and break open, releasing plaque into the bloodstream. The plaque can flow downstream and contribute to the formation of a blood clot, which can stop blood flow. As a result, limited blood supply is available to the areas surrounding the partially blocked artery, degrading and potentially killing the neighboring tissue. Significant damage in organs, such as the heart or brain, can result in a heart attack or a stroke.
So a deadly progression. Okay. Peripheral arterial disease is an atherosclerotic disease of arteries that perfuse the limbs, resulting in intermittent claudication. Okay. Coronary artery disease, any vascular disorder that narrows or blocks the coronary arteries leading to myocardial ischemia and death of the myocardial wall. Atherosclerosis is the most common cause. Risk factors: age, family history, male or female gender, postmenopause. Modifiable factors: dyslipidemia, hypertension, cigarette smoking, diabetes, if it's type 2, obesity and sedentary lifestyle, and atherogenic diet. Okay. Non-traditional risk factors are markers of high density C reactive protein, erythrocyte sedimentation rate, von Willebrand factor concentration, interleukin 6 and 18, TNF, fibrinogen, CD40 ligand. Okay. So let's talk a little bit about this. This is when we're talking about hyperhomocystemia. This is a medical condition that occurs when the body has abnormally high levels of homocysteine, an amino acid. Homocysteine is typically defined as having HHCY, the disease, is typically defined as having a homocysteine level above 15 micromole per liter. The main cause of this dysfunction is an enzyme abnormality and cofactors involved in homocysteine biosynthesis. Hyperhomocysteinemia can be present in many diseases and is an independent risk factor for more serious medical conditions. Okay. When these levels exceed 15 micromole per liter and are above normal limits, we have a disruption of the metabolism of homocysteine. Okay. Okay. Adipokines, also known as adipocytokines, are a large group of molecules that are secreted by fat cells and circulate in blood. They can act as hormones, growth factors, and cytokines and include molecules like leptin, adiponectin, resistin, and chemokine ligand 2. Adipokines help control many important body functions, including appetite, fat storage, glucose and fat metabolism, blood pressure, inflammation, and immune response. Okay. And then I don't know that we addressed troponin 1, did we? I don't think we did. Okay. All right. Myocardial ischemia is a local temporary deprivation of the coronary blood supply. It can manifest as stable prismental or silent, stable or prismental angina or silent ischemia. Okay. Stable angina, also called typical or angina or angina pectoris, is chest discomfort occurring during activity or emotional stress. It's caused by poor blood flow through coronary arteries, which carry the blood to the myocardium. Prismental angina, also known as variant angina or vasospastic angina, is a condition that causes chest pain while resting. It's caused by a temporary increase in coronary artery tone, which can narrow the lumen and cause spasm. This can lead to chest pain, and the ST segment of an electrocardiogram may show transient changes. Prismental angina usually occurs between midnight and early morning and responds well to nitrates. Silent ischemia occurs when the heart temporarily doesn't receive enough blood, but the person with the oxygen deprivation doesn't notice any effects. Silent ischemia is related to angina, which is a reduction of oxygen-rich blood in the heart that causes chest pain and other related symptoms. Okay. Acute coronary syndromes include transient ischemia, unstable angina, sustained ischemia, myocardial inflammation and necrosis, and myocardial infarct, which can either be STEMI or non-STEMI. Unstable angina is a condition that causes chest pain or discomfort when the heart doesn't get enough oxygen and blood flow. It's a type of angina pectoris that's irregular or more easily triggered. Unstable angina can lead to a heart attack. Okay. All right, let's look at MI in detail.
Cardiac compromise is a blanket term that refers to many kinds of problems with the heart. Just as there are many problems, there are a wide variety of signs and symptoms associated with these heart problems. As an EMT, it is much safer to treat all patients as though they are having a heart problem, rather than diagnose the specific disorder. With that in mind, let's take a closer look at 5 of the most common heart conditions. Coronary artery disease. Coronary artery disease occurs when the coronary arteries are narrowed or blocked, reducing the amount of oxygen delivered to the heart. 2 conditions, atherosclerosis and arteriosclerosis, commonly cause the narrowing or blockage of arteries. Atherosclerosis is a buildup of fatty deposits on the inner walls of arteries. This buildup causes a narrowing of the inner vessel diameter, restricting blood flow. Fats and other particles combine to form plaque. Arteriosclerosis is a stiffening or hardening of the artery wall resulting from calcium deposits. Often called hardening of the arteries, this condition causes the loss of elasticity, changing blood flow and increasing blood pressure. These conditions can facilitate rough surfaces, making them vulnerable to blockages. A large thrombus can cause an occlusion, or it may break loose to become an embolism and form blockages elsewhere. When blockage occurs, tissues may die, and in certain cases, this can be fatal. Acute myocardial infarction. Acute myocardial infarction occurs when a portion of the myocardium, heart muscle, dies as a result of oxygen starvation. The dead area can no longer pump. This can lead to cardiac arrest, shock, pulmonary edema, or congestive heart failure. In some cases, heart attack patients suffer cardiac rupture as the dead tissue area of the heart muscle bursts open. Medications called thrombolytics dissolve clots that block coronary arteries. Other patients receive an angioplasty, a balloon device, to open the arteries. Aneurysms. Weak spots that dilate are known as aneurysms. When a weakened artery bursts, rapid internal bleeding occurs, and tissues beyond the rupture can be damaged. A rupture of an artery within the brain can result in a severe stroke. If a major artery ruptures, death from shock can occur. Arrhythmia. A malfunction of the heart's electrical system will generally result in an arrhythmia. Electrical disturbances within the heart result in arrhythmias, including bradycardia, abnormally slow, less than 60 beats per minute, tachycardia, greater than 100 beats per minute, or rhythms that are present when there is no pulse, including ventricular fibrillation, ventricular tachycardia, pulseless electrical activity, and asystole. Congestive heart failure, CHF. Congestive heart failure, CHF, is a condition of excessive fluid buildup in the lungs and other organs because of inadequate pumping of the heart or a failure of the lungs to function properly. Congestive heart failure can be caused by diseased heart valves, hypertension, or some form of obstructive pulmonary disease. The symptoms of CHF may include tachycardia, shortness of breath, elevated blood pressure, cyanosis, profuse sweating, cool and clammy skin, pulmonary edema, pedal edema, or the coughing up of frothy white or pink sputum. Late signs include engorged pulsating neck veins or enlarged liver and spleen with abdominal distension.
So you can see here the triad that leads to this, right? Ischemia, left ventricular dysfunction, electrical instability. Okay. All interrelated, right? Let's take a look at ECG rhythms in a little bit more detail.
In this video, we will look at some of the most common and must-know ECG findings in medicine. We start with sinus rhythm, the normal rhythm of the heart. In this instance, there are regular P waves followed by a QRS complex that represents normal conduction of the electrical signals from the sinoatrial node in the right atrium through the atrioventricular node and bundle of His into the ventricles. The PR interval, which is the time between the start of the P wave and initiation of the QRS, remains constant throughout. The QRS complex itself represents ventricular depolarization and is normally narrow, typically between 80 and 100 milliseconds. In adults, if the rate is below 60 beats per minute, this is sinus bradycardia, and above 100 beats per minute is sinus tachycardia. Next, we have atrial fibrillation. In this case, there is abnormal electrical activity that leads to the atrial muscle fibers contracting at different times. It is these uncoordinated contractions that give the quivering or fibrillating activity. The ECG, therefore, has no clear P waves, with QRS complexes not being preceded by a P wave. Although the fibrillations can somewhat resemble a P wave at times, they will not be consistent. Only some of the electrical signals get conducted down into the ventricles and therefore lead to ventricular depolarization. But there's no real pattern of which impulses will get conducted. Therefore, we end up with the textbook irregularly irregular heart rhythm. This is described as a variable interval between the R waves on the ECG. Generally, it occurs as a result of a substrate that will maintain the arrhythmia, such as dilatation of the atria, and a triggering event, such as electrical activity arising from another atrial location. Most commonly, this is in the region of the pulmonary veins. Rates above 100 beats per minute are known as atrial fibrillation with rapid ventricular response, while those under 60 beats per minute are atrial fibrillation with slow ventricular response. I have a video dedicated to atrial fibrillation and will leave a link to it. Atrial flutter is often mistaken for atrial fibrillation. They are similar. The main difference is that atrial flutter features coordinated electrical activity in the atria due to a re-entry circuit, leading to rapid contraction of the atria. This is usually around 300 beats per minute, with a regular atrial rate and narrow complex tachycardia. As a useful side note, supraventricular tachycardia is an umbrella term to describe tachyarrhythmias with an origin above the ventricles that are classically described as narrow complex tachycardias. Examples include sinus and atrial tachycardia, as well as atrial fibrillation with rapid ventricular response and atrial flutter, amongst others. The ECG in atrial flutter classically shows a sawtooth pattern coming from inverted P waves, usually in the inferior leads. It is also described looking at the number of P waves compared to the number of ventricular contractions, showing the ratio of non-conducted to conducted beats. Most commonly, this is 2 to 1, giving a ventricular rate around 150 beats per minute. And higher ratios indicate a higher degree of block through the atrioventricular node. The term block here is not the same as the AV blocks that are coming up. It is worth noting that a conduction ratio of 1 to 1 is possible and is highly associated with instability and progression to ventricular fibrillation. These ratios can be variable in the same patient, making the ventricular rate irregular, which is why it can often be mistaken for atrial fibrillation. Now we have premature contractions, which are extremely common findings on ECGs. Premature ventricular contractions, or PVCs, are beats that originate from the His-Purkinje region of the conduction system, and therefore appear as wide complex beats above 120 milliseconds in duration. There is then a compensatory pause before the next beat. Although can be felt as palpitations, they are rarely dangerous alone, unless they are frequent, defined as over 10 to 30 per hour, and if happening every other beat, are described as bigeminy, while having a sequence of PVCs, one after the other, may be described as ventricular tachycardia, which we'll cover later on. Premature atrial contractions, or PACs, are seen as a P wave with a different morphology to the regular sinus P waves, followed then by a narrow QRS complex. The beat following the PAC may resemble a pause. However, if you track out the expected location of the P wave, it should fall at approximately the expected time. PACs do not typically require further investigation. Bundle branch blocks are another feature that are fairly common. In general, these are described as left or right bundle branch blocks. It's worth knowing as well that the left bundle branch splits again into the anterior and posterior branches. These patterns feature wide QRS complexes beyond 120 milliseconds. Left bundle branch blocks feature a deep S wave in V1 and prolonged R wave in V6, giving a W and M shape respectively, while right bundle branch blocks have an RS-R wave pattern in V1 and prolonged S wave in V6, giving M and W shapes respectively. An easy way to remember this is with the mnemonic William Marrow. Also remember that the ST segment is affected in bundle branch blocks, and so interpreting ST changes is challenging and needs specific criteria. Now let's take a look at the atrioventricular or AV blocks. First degree AV block is due to slowed conduction through the AV node, shown by a prolongation of the PR interval beyond 200 milliseconds. In general, this is a fairly benign finding, but can in some instances progress to higher degree blocks. Second degree AV block has two main types, called Mobit 1 or Wenckebach, and Mobit 2 or Hay. Mobit 1 features a progressive lengthening of the PR interval until there is a non-conducted P wave, then the cycle repeats. Mobit 2 features a non-conducted P wave with no variation in the PR interval. Type 2 is usually due to a structural abnormality and is considered high risk for progression to third degree, also known as complete, heart block. In third degree AV block, there is no association between atrial and ventricular contractions. On the ECG, this appears as P waves that do not lead to a QRS complex, and more P waves than QRS complexes, indicating a higher atrial rate than ventricular rate, which is most commonly severely bradycardic. Typically, there are regular P waves and regular QRS complexes, but no association between the two, with the QRS complexes being generated by junctional or escape rhythms. I also have a video dedicated to heart blocks that I'll link here. Next, we have ventricular tachycardia and ventricular fibrillation, which are two crucial ECGs to recognize. Ventricular tachycardia is defined as a broad complex regular tachycardia, the main type being monomorphic ventricular tachycardia, where there is a single source for the beats, and so the QRS complexes in one lead all look the same. Polymorphic VT is the term used when there is more than one source of the ventricular beats, and so gives varying morphologies of the QRS complexes. One famous example of polymorphic VT is torsades de pointes, occurring in the setting of a prolonged QT interval. Although other causes for a regular broad complex tachycardia exist, it isn't straightforward to distinguish them, and generally, if there is any diagnostic uncertainty, it is treated as ventricular tachycardia. Some features suggesting VT include very broad complexes above 160 milliseconds, absence of bundle branch block morphologies, and the presence of extreme axis deviation. Ventricular tachycardia itself can result in cardiac arrest, but may also degenerate into ventricular fibrillation, which is a lethal rhythm if not treated. There are no clear P waves or QRS complexes, and therefore minimal cardiac output. The ECG features chaotic electrical activity of varying amplitudes, with the amplitude correlating to duration. As time goes on, it reduces until asystole is reached. These two arrhythmias are associated with cardiac arrest, defined as cessation of normal blood circulation due to failure of the heart to pump blood, and are the two shockable rhythms in cardiac arrest, the non-shockable rhythms being pulseless electrical activity and asystole. Number 10 is one of the most famous ECG abnormalities, ST elevation. Although not an arrhythmia, it is an important ECG feature. On the ECG, this is the portion between the end of the S wave and the beginning of the T wave. Acute myocardial infarction is largely the most significant cause. However, there can be many other causes too, including pericarditis, left bundle branch block, left ventricular hypertrophy, and even a normal finding, such as in benign early repolarization. Typically, the elevation is defined as more than 1 millimeter from the isoelectric baseline in any lead, apart from leads V2 and V3 that generally require at least 1.5 millimeters. Also remember that different leads represent different territories of the heart. Leads 1, AVL, V5, and V6 are lateral leads, 2, 3, and AVF are inferior, while V1 to V4 are anterior and septal. For a posterior view, additional chest leads V7 to V9 are needed. In STEMI, you expect the elevation to be present in territories that are affected by the blocked coronary artery, and ST depressions in opposite territories termed reciprocal changes. which is why if ST depressions are seen in the anterior leads, an ECG with leads V7 to V9 should be done, which may reveal posterior STEMI. Check out my video specifically on ECG interpretation, and I recommend sources like Life in the Fast Lane and ECG Waves for further reading, which are the main references for this video.
Disorders of the heart wall include pericardial disorders, acute pericarditis, pericardial effusion resulting in cardiac tamponade, and constrictive pericarditis, which is a chronic condition that occurs when the pericardium thickens and becomes fibrotic, limiting the heart's ability to function. This is caused by granulation tissue formation in the pericardium, resulting in a loss of elasticity and restriction in ventricular filling. This condition is often characterized by chronic scarring, fibrosis, and calcification of the pericardium and is associated with diastolic dysfunction. Cardiomyopathies include dilated cardiomyopathy, which can be an outcome of congestive heart failure, and hypertrophic cardiomyopathy, which can be broken down into asymmetrical septal hypertrophy and hypertensive cardiomyopathy. And then finally, we have restrictive cardiomyopathy. And you can see them all diagrammed here on the right. Okay. Notice that with dilated cardiomyopathy, what do we see? Well, we're going to see left ventricular dilation because you're working against greater afterload. Okay. And the chamber can become distended and can over time weaken. Okay. With hypertrophic cardiomyopathy down in C, we see thickened walls, and this is often, again, due to conditions such as valvular stenosis, okay? And then restrictive cardiomyopathy or amyloid cardiomyopathy, again, you can see the thickened walls and the result of working against, again, greater resistance, okay, is due to amyloid plaque buildup. All right. We're going to break this down further in the overview here. So let's take a look.
Hey guys, Nurse Mike here, and welcome to SimpleNursing.com. Now, before we get today's lecture started, please remember to access your free quiz and preview our cool nifty few study guides, not here on YouTube. Click the link right up here at any time during this video. All right, guys, let's begin. Timmy's a 9-year-old male who plays on his school soccer team. Recently, he has been getting very short of breath during soccer practice, so his mom took him to see his pediatrician. Timmy's doctor found that he has a significant heart murmur. Oh snap! What could it be, and what are the priority nursing interventions you must know for not only your tests, but ultimately the NCLEX? Today we're wrapping up cardiomyopathy, or what my mom calls cardiac mayonnaise. What happens when the cardiac muscle gets either too thin, too hard, or even just really big and thick, all leading to a weaker pump, meaning low cardiac output, aka low oxygen to the body. Now, there are 3 different types of cardiomyopathy that affect the cardiac muscle. So we use the acronym Dr. H. D stands for dilated cardiomyopathy. So remember D for distended and thin heart muscles, kind of like a balloon. R is for restrictive cardiomyopathy. So remember R for rock hard, rigid cardiac muscle. And H is for hypertrophic. So remember huge trophy-like, big and thick heart muscles. Now there are 2 categories of cardiomyopathy. It's either primary or secondary. Primary develops all by itself, and secondary is usually caused by hypertension or some sort of valve disease. But before we further break down the causes, let's define what cardiomyopathy is. So the fancy medical definition of cardiomyopathy, cardio meaning heart, myo meaning muscle, and pathy meaning disease. So cardiomyopathy is a disease of the heart muscle, the myocardium, which inhibits effective pumping. Essentially, we have pump failure problems here, which again leads to this less cardiac output, basically meaning less oxygen to the body. So what's really going on in the body? Well, as you guys know, the heart acts like a pump, pumping oxygen-rich blood out to the body from the left ventricle. Now, the ventricles stretch as they fill with blood, and this is the end of diastole, called preload. And then, well, when they fill, they have to squeeze out all that oxygen-rich blood to the body. This is where they overcome all that pressure called afterload. Now, the amount of oxygen-rich blood being pumped out of the heart to the body per minute is what's called cardiac output. All that blood coming out of the heart. It's when the heart cannot pump correctly when we get less cardiac output, meaning less oxygen-rich blood out to the body. And that's when we get loads of problems. So again, we're going to review these one by one, but just again, little overview. Dr. H. D is for our dilated, distended cardiomyopathy. This is where the ventricles sort of balloon out and have very thin muscle walls, as you can see right here. Next is our restrictive, rock-hard cardiomyopathy. The ventricles get super stiff like a brick wall and technically don't pump correctly. And H is for our hypertrophic cardiomyopathy, where the ventricles do the exact opposite. They beef up and get really thick and hard like a big, huge trophy. So let's start with the first one, dilated, which I call distended cardiomyopathy. Now, this guy is the most common out of our three wise men here. Here we have distended muscle walls, where the chambers in the heart are being stretched out like a saggy, loose sock, leaving us with big, stretched out chambers and really loosening up the valves so they don't close all the way. This results in a weaker contraction, basically not an effective pump, or no effective systolic squeeze for our blood pressure. And this leads to pump failure, specifically systolic heart failure, where the blood doesn't go forward and now it backs up into the lungs and or body. And when blood backs up, again, this means less blood being pumped out of the heart to the body. And again, this is called less cardiac output, meaning less oxygen to the body. As a result, the body thinks we have low blood pressure. So the body attempts to increase this blood pressure by stimulating the sympathetic nervous system to increase the heart rate. It also attempts to increase the blood pressure by stimulating the kidneys to initiate the renin-angiotensin-aldosterone system, fancy words for the RAS system, which results in the kidneys holding on to the fluid, which increases blood pressure. But over time, these compensatory mechanisms can no longer maintain cardiac output and the heart begins to fail. So we're going to see classic heart failure signs and symptoms, all revolving around low oxygen signs and symptoms from this low cardiac output. So low oxygen in the brain will see syncope as well as mental status changes. Now, exams in the NCLEX love to really emphasize that restlessness and agitation is the earliest signs of hypoxia. So guys, write that down. Restlessness and agitation are usually the first signs that indicate low oxygen. But we'll also see in the heart angina and ECG dysrhythmias, or basically a heart block. And for the respiratory tract, we'll see shortness of breath called dyspnea. So you'll see rapid, shallow breathing. Now, as far as heart failure signs and symptoms, blood fails to pump forward and now starts to back up in the body and or the lungs. So if blood backs up on the left side of the heart, remember L for left means L for lungs. We hear wet crackles inside the lungs, known as pulmonary edema. Thanks for watching. For our full video and new quiz bank, click right up here to access your free trial. And please consider subscribing to our YouTube channel. Last but not least, a big thanks to our team of experts helping us make these great videos. All right, guys, see you next time.
Disorders of the endocardium, shown here. Valvular dysfunctions include valvular stenosis, which can be split into aortic and mitral stenosis, valvular regurgitation, which includes aortic, mitral, and tricuspid regurgitation, and mitral valve prolapse. Now, all of these result in heart murmur, and all of these result in blood flowing in two directions in the case of a prolapse or a regurgitation, okay? Or in the case of a stenosis, what you're going to see is dilation of the chamber that is upstream of the stenosis, of the narrowed valve, okay? Because that chamber is having to work harder to pump the blood through a narrow opening, all right? Acute rheumatic fever. It's a systemic inflammatory disease caused by delayed immune response to pharyngeal infection by group A beta hemolytic strep. It's a febrile illness causing inflammation of the joint, skin, nervous system, and the heart. And if left untreated, it can cause rheumatic heart disease. Okay. Common manifestations: fever, lymphadenopathy, arthralgia, nausea and vomiting, tachycardia, abdominal pain, and epistaxis. Major clinical manifestations: carditis, polyarthritis, chorea, and erythema marginatum. Okay. Um, Lymphadenopathy, swollen and painful lymph nodes. Arthralgia is joint pain. Tachycardia, rapid heart rate. Okay. Epistaxis, nosebleed. Okay. Carditis, inflammation of the lining of the heart. Okay. Polyarthritis, again, multiple joints undergoing inflammation. All right. And erythema marginatum, that one I'll have to look up. Okay. So let's take a look at infective endocarditis.
Infective endocarditis is a life-threatening infection of the heart, specifically the endocardium, which is the innermost layer of the heart. Most commonly, this is from a bacterial infection involving the heart valves. For infectious endocarditis to develop, there needs to be the presence of a bacterial infection in the blood, termed bacteremia. There are rare exceptions, such as a contaminated prosthetic valve being installed. Bacteremia can come from the transition of bacteria from another infection site into the blood, introduction via intravenous drug use, and from procedures like dental procedures. However, the endocardium is normally resistant to colonization by microorganisms. Therefore, for infectious endocarditis to develop, there also needs to be an injury to the endocardium. This could come from turbulent blood flow, direct injury from solid particles injected during intravenous drug use, mechanical injury from devices, and chronic inflammation, such as in autoimmune conditions. This injury causes formation of fibrin platelet deposits, termed non-bacterial thrombotic endocarditis, to which bacteria are able to adhere and to proliferate, forming a vegetation that is then covered by a biofilm protecting it. Particles from the vegetation can also detach and travel along the bloodstream, forming septic emboli, and therefore can affect other organs. That brings us on to the complications. Cardiac complications include valvular insufficiency, most commonly the aortic and mitral valves, and less commonly the tricuspid valve. Ultimately, this can lead to the development of heart failure. Cardiac abscesses can also form, most commonly in the aortic root, and emboli may travel down the coronary arteries and generate a myocardial infarction. The central nervous system is commonly affected, including ischemic and hemorrhagic strokes and the formation of cerebral abscesses. Mycotic aneurysms, which are aneurysms caused by infection of the vessel wall, can form throughout the body's vasculature, but they are particularly common in the cerebral vessels. Emboli can travel to the kidneys and cause renal infarctions, and immune complexes formed to the emboli can deposit in the kidneys, causing glomerulonephritis. The spleen is also a common site of embolization, leading to infarction and abscess formation. If the emboli go into the pulmonary circulation, such as when the tricuspid valve is affected, this can lead to septic pulmonary embolism. Fever is present in 97% of people, often being persistent with no obvious other cause, and may be associated with rigors or night sweats. Fatigue is common, and patients may also complain of dyspnea or shortness of breath on exertion, and chest pain in some cases. Hematuria is also possible if there is renal involvement. On physical exam, there may be a new or changing heart murmur, and there may be blackening of the extremities if emboli have reduced the blood flow. Janeway lesions are painless cutaneous lesions on the palms of the hands and soles of the feet, and are the result of microemboli, and splinter hemorrhages can be seen in the nail beds due to capillary injury. Often confused with Janeway lesions are Osler nodes, which are painful erythematous nodules, typically on the tips of the fingers and toes, thought to be due to a local immunological response. Roth spots are visible on fundoscopic examination of the eye as small white-centered retinal hemorrhages coming from retinal capillary rupture. We've said that bacteremia and a predisposing endocardial insult are typically needed for infective endocarditis. Specifically, structural heart disease is the largest risk factor, which used to be commonly from rheumatic heart disease. However, in the developing world, it remains the most common predisposing factor. Prosthetic valves and cardiac devices like defibrillators and pacemakers are significant risk factors present in around 1 in 4 cases of infective endocarditis. Underlying congenital causes of structural heart disease were present in around 12%. Other factors include intravenous drug use, an immunocompromised state, which can allow bacteria to reach higher concentrations in the blood. Another major factor is exposure to healthcare settings, which is thought to account for 1 in 3 cases in the developed world. As we said, the infection is usually bacterial, and the most common causative microorganism varies by country, generally between Staphylococcus aureus and Streptococci. But from recent study averages, Staphylococcus aureus is present in around 26.6%, Streptococcus viridans species in 18.7%, followed by other Streptococcus species at 17.5%, and Enterococcus in 10.5%. These make up over 80 to 90% of causative agents, with the remainder being gram-negative bacteria, including the Hackett group, or fungi like Candida albicans. Infective endocarditis is most commonly seen in patients over the age of 50, which is a relatively recent change because in the early 1900s, it was most common in patients under the age of 30. This is because back then, rheumatic heart disease was the main risk factor, which is more common in younger patients, while now, degenerative disease, which is seen in older patients, is more prominent. Also, the general population is older and therefore more prone to exposure to healthcare. Around 2 out of 3 patients are male, and although the incidence is less than 10 in 100,000, there is an associated 30-day mortality of 30%. The diagnosis is based on a set of criteria known as the Duke criteria, which were revised in the year 2000 and are now known as the modified Duke criteria. They are divided into pathological criteria and clinical criteria, where pathological criteria include histology or culture of vegetation or a cardiac abscess suggesting active endocarditis. If either of these are present, then a definite diagnosis is made. Clinical criteria are divided into major and minor criteria. Major being supporting lab evidence of a typical organism present in 2 separate blood cultures, and evidence of endocardial involvement on echocardiogram. Minor criteria include a predisposing factor, such as a heart condition or IV drug use, a fever above 38 degrees, the presence of immunological phenomena like glomerulonephritis or Osler nodes, vascular phenomena such as arterial emboli, mycotic aneurysms, or Janeway lesions. A blood culture that is positive but does not feature a typical agent is also a minor criteria. A definite diagnosis is made if there are 2 major criteria, 1 major and 3 minor, or 5 minor. The mainstay of treatment is intravenous antibiotics, usually an extended course of 2 to 6 weeks because the bacteria are protected and in a location that is not easy to reach. Agents like vancomycin and ceftriaxone are favored as empirical agents to be used after the initial blood cultures are taken. This is important as taking blood cultures after starting antibiotics can lead to negative cultures. Once cultures are grown, specific antibiotic sensitivities can be used for specific antibiotic therapy. Antibiotics may be given prophylactically when a predisposed patient is due to undergo certain procedures, such as dental procedures, but the evidence behind this is not always definitive. Valve replacement may be needed in some cases, such as significant regurgitation, hemodynamic compromise, or complications.
So you can see the flow chart here, right? Pathophysiology, infective endocarditis, which is inflammation of the inner lining of the heart. Congenital heart disease, valvular heart disease, trauma, prosthetic valves, right? We damage the endocardium, we get inflammation and thrombus formation, sterile thrombotic endocarditis, and then we have the potential as a result of other procedures to introduce bacteria into the bloodstream. The bacteria attach to the irregular surfaces. We get fibrin and thrombus formation, formation of vegetations, and you can see embolization, abscesses, petechiae, splinter hemorrhages, Osler nodes, Janeways, fever, night sweats, malaise, weight loss, murmurs, regurgitant valve, and heart failure. The bacteria like to grow on the irregular surfaces, making biofilms, and that's going to interfere with valve function. In addition to which, the bacteria can become part of traveling material in the blood that can block blood flow to various parts of the heart and the rest of the body. Okay. Cardiac complications of AIDS. Remember that in AIDS, what happens is that the helper T population is compromised because the human immunodeficiency virus invades the helper T cells and turns them into virus factories, and taking them off task. In addition, it causes them to express fast ligand, which kills other white blood cells they come into contact with. And so your adaptive immunity and your white count decline precipitously over time, unless you're undergoing, again, um, treatment for the condition, which we now have. Highly active antiretroviral therapy has turned AIDS from a death sentence into a chronic disease in many cases. Okay. But cardiac complications, myocarditis, endocarditis, pericarditis, cardiomyopathy, pericardial effusion, pulmonary hypertension, and non-antiretroviral drug-related cardiotoxicity. Heart failure is just a general term to describe several types of cardiac dysfunction resulting in inadequate perfusion of tissue with blood-borne nutrients. Left-sided heart failure or congestive heart failure is the inability of the heart to generate adequate cardiac output to perfuse the tissues, resulting in remodeling of the ventricle. Causes include myocardial infarction, myocarditis, cardiomyopathy. Okay. So, again, what's happening here is that the left side is not keeping up with the right side of the heart. All right. So, when the left side of the heart is not keeping up with the right side of the heart, the blood is going to pool in the lungs, and that's going to result in a pleural effusion. Okay. Diastolic heart failure, pulmonary congestion, despite normal stroke volume and cardiac output. Causes include myocardial hypertrophy and ischemia, diabetes, valvular, and pericardial disease. All right. Manifestations, okay. Pulmonary vascular congestion, inadequate perfusion of the systemic circulation. Includes dyspnea, orthopnea, cough of frothy sputum, fatigue, decreased urine output, edema. Physical exam often reveals pulmonary edema with cyanosis, inspiratory crackles, and pleural effusion. Hypotension or hypertension, an S3 gallop, and evidence of underlying um, coronary artery disease or hypertension. Okay, so you can see there the um, the results, right? The right side is continuing to pump its normal volume. The left side is not. All right, the blood has to pool in the lungs, and those are the results. In addition to which, the systemic supply is going to be reduced, right? This can be caused by, in the case of right-sided heart failure, most common cause by diffuse hypoxic pulmonary disease that can result from an increase in left ventricular filling pressure that's reflected back to the pulmonary circulation, right? So what's happening here, all right, is that the right side of the heart isn't keeping up with the left side of the heart. And so where is the blood going to pool? It's going to pool in the body. And so you're getting a peripheral edema, as shown here, right? And you're going to end up with an increase in right ventricular and right atrial preload, and an increase in right ventricular end diastolic pressure, and a decreased force of contraction. Okay. You're going to get right ventricular hypoxia, increased right ventricular oxygen demand, increased force of right ventricular contraction, increased vascular resistance. Okay. And of course, all of this is going to result in decreased oxygen supply, because there's usually an underlying disease in the lungs resulting in scar tissue that is going to impede gas exchange. Okay. High output failure. Okay. Is the inability of the heart to supply the body with blood-borne nutrients despite adequate blood volume and normal or elevated myocardial contractility. Causes include anemia, hyperthyroidism, septicemia, and beriberi. Okay, so with anemia, what's happening is that we have impaired oxygen delivery resulting in tissue hypoxia. Okay, this can result in the release of catecholamines, an increase in heart rate and stroke volume, and an increase in cardiac output to compensate, right? With sepsis, okay, you're going to see an inflammatory response. You're going to see a decrease in systemic ventricular resistance because of the dilation of all your capillary beds at the same time, okay, due to systemic histamine release, okay? That results in impaired oxygen delivery, okay? You're going to trigger fever, which is going to increase oxygen demand from tissue. You're going to get tissue hypoxia, resulting in release of catecholamines and an increase in heart rate and stroke volume and an increase in cardiac output, right? Hyperthyroidism, thyroid hormone elevates your basal metabolic rate, right? So you're going to end up seeing high oxygen demand from tissue, okay? Tissue hypoxia, and then the same thing, increase in catecholamine release, heart rate, stroke volume, increase in cardiac output, okay? All right. Now, shock is where the cardiovascular system fails to perfuse the tissues adequately, leading to impaired cellular metabolism, reduction in oxygen use, and impaired glucose use. Manifestations vary depending on the stage, but often we see hypotension, tachycardia, and an increased respiratory rate. So let's take a look at shock in a little bit more detail. Okay.
So when we talk about ischemia, we're usually talking about this lack of blood flow to a specific area of tissue. So maybe like with a heart attack, a coronary artery in the heart gets blocked that supplies the left ventricle with blood. So that localized area of heart tissue doesn't get enough blood and oxygen, and that damage is localized to that left ventricle. Shock is like ischemia, but on a global scale. In other words, it's a whole body circulatory failure, where blood flow to tissues is dangerously low, leading to cellular injury, possibly damaging multiple organs, and even leading to multiple organ failure if not treated immediately. Okay, so with shock, the body's tissues aren't getting enough oxygen via the blood, right? Normally, blood perfuses through tissue and delivers oxygen because there's enough pressure in the circulatory system to push it through. So blood pressure is a major determinant for the amount of blood perfusing through tissues. Now, blood pressure is determined by two components: the resistance to blood flow in the blood vessels, things like vessel length, blood viscosity, and vessel diameter, and the cardiac output, which is the volume of blood pumped by the heart through the body per minute. And you can break that into heart rate, the number of beats per minute, times stroke volume, the amount pumped out each beat. Going even further, the stroke volume is found by taking the total volume of blood left over after contraction, the end systolic volume, and subtracting it from the total volume in the heart after filling, the end diastolic volume. All right, now keeping all those in mind, shock can be caused by a whole bunch of different things, but we can categorize the different types of shock into three main categories, along with some subcategories here and there. The first category is called hypovolemic shock. Hypo means low, vol refers to volume, and emia refers to the blood. So hypovolemic shock is shock induced by a low fluid volume of blood. And this could be either non-hemorrhagic or hemorrhagic. Non-hemorrhagic means that the loss of fluid volume isn't from bleeding. So this could be like if you were stranded in a desert and suffered severe dehydration. Eventually, your loss of fluid and sweat would reduce blood volume to where it wouldn't be enough to supply your body's organs, and you develop hypovolemic shock. Hemorrhagic hypovolemic shock, on the other hand, is loss of blood volume through ruptured blood vessels. In other words, from bleeding. A loss of about 20% of your total blood volume, roughly 1 liter, can be enough to induce hypovolemic shock. And when that liter of blood leaves the circulation, the total volume filling into the heart goes down, meaning the end diastolic volume goes down, right? This means stroke volume goes down as well, which causes cardiac output to go down, and finally we see that blood pressure goes down. When cardiac output goes down, catecholamines like epinephrine and norepinephrine, ADH and angiotensin II are released, all of which cause vasoconstriction of blood vessels, which increases vascular resistance and increases heart rate, which increases cardiac output. And these combined effects all increase blood pressure. A super important indicator of tissues not getting enough oxygen due to hypovolemia is a decreased mixed venous oxygen saturation, or MVO2. MVO2 is the amount of oxygen bound to hemoglobin in blood coming to the right side of the heart from the tissues. So it's like the amount of oxygen left over, or not extracted and used by the tissues. So if blood volume's down, that means oxygen's down, and there's going to be less left over, right? So MVO2 will be down with hypovolemic shock. Since blood flow provides heat to the tissues as well, when it's down, the skin starts to feel cool and clammy, and so hypovolemic shock is considered a cold shock. A second main category of shock is cardiogenic shock. Cardiogenic means produced by the heart, right? So this is when something happens to the heart such that now it can't pump enough blood to the body's tissues. The most common cause is acute myocardial infarction, or heart attack. Hold on a second, though. Didn't I say at the beginning that that was more along the lines of localized ischemia? Well, the heart attack itself reflects ischemia, right? But these effects of the initial cardiac damage eventually leads to a state of shock. When the heart's muscle cells die, it can't contract as hard, which means the amount of blood pumped out, or stroke volume, goes down, and therefore cardiac output goes down as well. In the same way as with hypovolemic shock, the body releases vasoconstrictors to increase vascular resistance and help maintain blood pressure. Also, as with hypovolemic shock, MVO2 will be down since there's less oxygen being pumped out, and so less will be left over. Sometimes there might be an obstruction that doesn't allow the heart to fill properly with blood. For example, we might have the pericardial sac fill up with fluid from an infection or blood from a traumatic accident, like getting stabbed in the chest. If this sac fills up, it physically constricts the heart from expanding and contracting normally, and also reduces the stroke volume. This is sometimes subclassified as obstructive shock. But you can see that the cause is still due to the heart's inability to do its job, right? Similarly to hypovolemic shock, a reduction in cardiac output leads to lowered blood flow, so the skin gets cool and clammy, and so cardiogenic shock is also considered a kind of cold shock. All right, the third main category of shock is called distributive shock, where there's typically a leakiness of blood vessels and an excessive amount of arterial vasodilation, or widening of the peripheral blood vessels, which remember is one of the components of vascular resistance. If arterioles dilate, vascular resistance to blood flow goes down and blood pressure goes down, leading to less perfusion and distribution of blood to organs and tissues. Now, the most common type of distributive shock is septic shock from pathogens in the blood. What happens with septic shock is endotoxins, these large, clunky lipopolysaccharide molecules, sometimes just called LPSs, found in the outer membrane of gram-negative bacteria, causes a crazy cascade of events that ultimately leads to lowered perfusion. First, these guys directly damage endothelial cells and cause them to release vasodilators like nitric oxide. They also activate the complement pathway in the blood, which stimulates mast cell release of histamine, another vasodilator. The LPS molecules also activate immune cells like macrophages and neutrophils, which help create a bunch of pro-inflammatory cytokines like tumor necrosis factor and interleukin-1. These help the immune system destroy the invaders, but they also stimulate the endothelial cells to release more inflammatory molecules like platelet activating factor and reactive oxygen species. All of these inflammatory chemicals damage the endothelial cells and increases their vascular permeability, making the blood vessels leaky. Also, endothelial cells express a procoagulant called tissue factor. Procoagulants are molecules that increase blood coagulation, or blood clotting. And this, in combination with an overall decrease in anticoagulants, which usually decrease clotting and seem to be often depleted or used up during sepsis, leads to this net increase in coagulation and clotting in the microvasculature. And of course, clotting and blockages in the blood vessels further decreases perfusion, right? Okay, so this widespread vasodilation means very little vascular resistance, and blood can't get the chance to unload as much oxygen as it cruises through the vasculature. and it gets back to the right side of the heart with leftover oxygen. So in this case, as opposed to cardiogenic and hypovolemic shock, MVO2 can be normal or even increased. In contrast to hypovolemic and cardiogenic shock, now there's an increase in flow in the peripheral blood vessels, and the skin becomes warm and flushed. So distributive shock is a kind of warm shock. The overall combined effects of widespread vasodilation, increased vascular permeability, and microvascular blood clotting all contribute to decreased perfusion of blood to vital organs. Now, two kind of subtypes of distributive shock are anaphylactic shock, which is an allergic reaction that causes dangerously low blood pressure, and neurogenic shock, where the nervous system gets damaged and can't control the body's blood pressure. The treatment of shock depends on the cause. In general, the goal is to stabilize blood pressure so that vital organs like the heart and the brain are perfused with blood. In order to stabilize blood pressure, fluid replacement and medications that increase heart contractility, cause vasoconstriction, and retain fluid can be administered. Oftentimes, a person might need supplemental oxygen or have their airway protected, for example, with intubation. All right, as a quick recap, shock is ultimately a failure in tissue perfusion, and it affects the whole body, putting tissues and organs at risk for injury and ultimately organ failure. Hypovolemic shock happens when dehydration or hemorrhage reduces the volume of blood in the blood vessels. Cardiogenic shock happens when a direct injury like a heart attack or an obstruction like a pericardial effusion prevents the heart from pumping blood efficiently. Distributive shock happens when something like an allergic reaction or damage to the nervous system, called neurogenic shock, causes the blood vessels to vasodilate and become leaky, which reduces the resistance and lowers the blood pressure.
So we can see the different types of shock, right? We've got a reduction in cardiac output, all right? So either we're dropping the heart rate or the stroke volume. We see compensatory renin-angiotensin-aldosterone kick in, and then we see the sympathetic division of the autonomic nervous system kick in. And what are we going to do? We're going to increase blood volume, and that's going to help to increase blood pressure. And with catecholamine release, we're going to increase the stroke volume, and we're going to increase the ejection fraction. Okay, so this increases the preload, the stroke volume, and the heart rate. This can lead to systemic and pulmonary edema and dyspnea. Okay, an increase in myocardial oxygen requirement results in a reduction in cardiac output and a reduction in ejection fraction. This reduces tissue perfusion. This leads to ischemia, which reduces cellular metabolism and causes myocardial dysfunction, and the loop repeats and repeats. And of course, blood pressure goes down and down and down as a result of this. Okay. Decreased intravascular volume results in a drop in cardiac output. Okay. This can be either as a result of shift of interstitial fluid, can be the result of a reduction in the production of aldosterone and ADH, okay, which is going to reduce fluid volume, okay, and can result in reduction in splenic discharge. Now, to compensate for this, all of these will try to kick up, all right? You'll see an increase in blood volume, an increase in cardiac output, more volume loss, results in a reduction in cardiac output, reduction in tissue perfusion, and impaired cellular metabolism. The reduction in cardiac output also causes reduction in systemic and pulmonic pressure. Okay. And of course, we have to consider again that the sympathetic division of the autonomic nervous system is going to kick in, as will the endocrine system. And we're going to see an increase in heart rate and contractility due to norepinephrine and epinephrine. Okay. And all of this will, again, feed into the loop at the bottom, okay? An imbalance between sympathetic and parasympathetic stimulation can cause massive vasodilation, a decrease in vascular tone, a decrease in stroke volume, and inadequate cardiac output, reduction in tissue perfusion, reduction in metabolism. Okay. Okay. This is one of the things we see in septic shock or in toxic shock. We get global histamine and cytokine release. We get dilation, systemic dilation of blood vessels, and that reduces your blood pressure dramatically. Okay. Um, we get relative hypovolemia, a reduction in cardiac output, reduction in tissue perfusion, and a drop in cellular metabolism. Okay. You can see here an example, right, of what the immune response is going to be to a blood infection. All right. Exotoxins and endotoxins trigger attraction of macrophages, which are going to respond to interleukin 1, TNF, and nitric oxide. We're going to see fever, tachycardia, tachypnea, leukocytosis, and bacteremia, leading to sepsis, vasodilation, hypotension, tissue inflammation, tissue hypoperfusion, myocardial depression, worsening tissue hypoperfusion, and multiple organ failure. All right. Basically, we've opened up all the blood vessels wide open. We've dropped the blood pressure too far. Okay. The heart tries to compensate, it can't. All right. And then we have the delivery of the toxins and the pathogen to every tissue in the body. Okay. Multiple organ dysfunction is a progressive dysfunction of two or more organ systems resulting from an uncontrolled inflammatory response to severe illness or injury. Causes sepsis, septic shock, severe injuries such as trauma, burns, and major surgery. We see respiratory, hepatic, renal, GI, and myocardial implications, okay, such as, okay, we have injury, sepsis, or disease, endothelial damage, release of inflammatory mediators, activation of complement, coagulation, massive systemic immune and inflammatory response, vasodilation everywhere, okay? Maldistribution of systemic and organ blood flow, tissue hypoperfusion, reduction in cardiac function, myocardial depression, okay? On the other side, right? Hypermetabolism, increased oxygen and substrate demand, exhaustion of fuel, metabolic failure, right? Oxygen demand and supply imbalance, supply dependent oxygen consumption, tissue hypoxia, acidosis, okay? Now you might wonder, well, why is this? Well, you're reducing the metabolic rate, right? And so you're reducing um, consumption of oxygen. You're depressing respiratory rate because of hypoxia. You're not washing away the CO2 in the tissues. Okay. You see organ dysfunction and multiple organ failure and death.